Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Oh, hi, Michael.
Hey, how are you?
I'm fine, thank you. And thank you for joining me today for this conversation. We've been chatting for a while, but now that we are officially live, I will introduce myself briefly. My name is Katarina. I'm a medical oncologist. I'm doing my PhD in exercise for patients with advanced cancer. This was also the topic of my master's that I did a few years ago. So I have this personal and academic interest in lifestyle interventions for cancer patients in general. So this is kind of my mission to shed a light on these and raise awareness for the need to integrate this both in clinical practice, but also in research. And tell me about you, Michael. You have had an amazing career. You've led some of the best rehabilitation clinics for cancer patients in the US. Who are you, and what led you on this journey?
Yeah, well, thank you. First of all, I'm very appreciative of you having me here. It's been fun talking before, but I'll repeat all that again. So I started off really, small town in California, ended up getting as far away from the small town as I could. So I ended up at Brown University in Providence, Rhode Island, which is, one of our Ivy League schools, which I had no idea what that really meant when I was a high school kid. I majored in biology and did honors in philosophy. Knowing that I wanted to be a doctor, is also pre-med. So I ended up at Columbia Medical. Um, I thought I was going to be an orthopedic surgeon. Didn't really like orthopedic surgery, but somebody told me, there's this field called rehabilitation that does a lot of the hands-on part. I like that, hands-on, Sherlock Holmesy, let's figure out what's wrong with somebody by knowing the history and examining them. That appealed to me. So internal medicine also appealed to me. So I ended up doing a combined program in internal medicine and rehab medicine. I also did a lot of EMG. So I'm boarded currently, and I've recertified all my boards in internal medicine, rehab medicine, electrodiagnostic medicine. So it still didn't mean I had any idea what I was going to do for a living when I grew up. So this job opened up at Sloan Kettering. It'd been open for a year or two. I just heard about it through a friend. I'm like, cancer rehabilitation, that seems interesting. I like the complexity of the cancer patients and all the medical issues associated with the cancer patient. So pretty sure I was the only real applicant for the job. I ended up getting it. And when I started, it was just me and maybe 10 or a dozen therapists, largely doing inpatient to try to mobilize the patients in the hospital and get them out to wherever they were. We had no outpatient services, whatever. But sort of naively, right, I'm looking at these patients and trying to apply the skills I had, which were really neuromusculoskeletal from all the EMG I did, and, sort of the emphasis on sports medicine in rehabilitation medicine in the US these days. I guess those were in the olden days, but it's still that way. So I started seeing patients, I think, a little differently in terms of how I evaluated them from my colleagues. We had a great pain and palliative care service. But I like to joke, if you sent a cancer patient with a shoulder problem to pain and palliative care, they said, hey, cancer patient with pain. They would start them on Tylenol, work them up to heroin, which was kind of the way of doing it. They were really just climbing the pain ladder, which was the vogue at the time, but not really getting into what was actually wrong with the patient, which was almost always neuromusculoskeletal. It was post-mastectomy pain syndrome, adhesive capsulitis. They might have rotator cuff tendonitis. They might have radiculopathy. I would look at them very differently. And again, this was a learning process because I didn't at the time really know how to incorporate their surgery and everything else into what was going on the way we do now. So I would give them a suprachoroidal injection and I'd start them on anti-inflammatories or nerve stabilizers. I'd send them to outpatient therapy. Never dawned on me to use opioids on most of them because it was really a neuromusculoskeletal issue and they got better. And that made me very popular very quickly, both with the patients and more so with the doctors, because what I found was my superpower was taking over all the stuff the other doctors didn't want to do. Right. So no oncologist, I'm sure you know this, maybe you're different because you like this sphere, but most of the oncologists, they want to kill cancer. They want to deal with cancer complications. They don't want to deal with cognitive issues and shoulder problems and pain and gait issues and all of the other stuff that's the playground for rehabilitation physicians. So that just filled up my clinic. I was able to expand one of my head and neck cancer patients. I really have kind of begun to specialize. I see everything, but in radiation late effects. And again, because everybody just didn't look at them from the neuromusculoskeletal lens, and I did. So he gave us $17 million. We built a new outpatient center. We grew to like 100 therapists, 5 physicians, 20 support staff. We got very busy and it was good. But the problem was I was still in Manhattan. So if you were wanting to see me, unless you lived in Manhattan, if you were coming from New Jersey or something, it's, the bridge toll, you had to pay to park, you had to pay for lunch, you had to pay your copay. It was really just for people who had resources. And that was really making it unavailable to people across the world. And that was frustrating because you'd commonly have conversations with people about, I'd love to help you, but this is kind of the cost of admission. So when the opportunity came for me to go to Kessler and Select Medical, I jumped at it. So Select Medical is a giant rehab company. Like they're a Fortune 500 rehab company, like $5 billion a year, something like that, annual revenue, 50,000 employees. We have 35 rehab hospitals, including Cleveland Clinic, Baylor, Emory, Cedars-Sinai, UCLA, of course, the Kessler hospitals that we either own, like the Kessler hospitals, or joint venture with. We have 1,000 plus outpatient therapy sites, 100 long-term acute care hospitals. And it's a very well-run, kind of family-run business. That I joke, our product is function and quality of life. That's what we do, right? We help people get better. And most of the people who climb to the echelon have been, therapists and nurses who've, just learned how to do this or gone out and gotten their MBA. So it really is about taking care of the patients, but doing it in an economically responsible way because, you are still running a business. So they brought me on to kind of start looking at cancer and to see what we could do with the cancer program. So ultimately what that turned into is our ReVital Cancer Rehab Program. So ReVital is really a training, education, certification program, completely internal to our thousands of therapists and only the ones who want to do it. And it takes several months for them to go through the training. We have several levels of training. So you can become ReVital certified. Then you can become a ReVital specialist. That takes a year or two. And then you become a ReVital educator, which is the equivalent of doing a fellowship in cancer rehabilitation through like one of the therapy programs that offer that or equivalent to the American Physical Therapy Association. Now we offer it to PTs, but also SLPs and occupational therapists. And we currently have trained over 1,000 therapists. We're operating in 25 states, several hundred clinics. And we're seeing, I think this year, about 300,000 visits a year. There was a recent study looking that not that we sponsored, but just looking at rehabilitation services in the country. And it turns out 70% of the facilities in the United States are ReVital facilities. And I feel like we're still in first gear. We've just started in terms of providing these services, but they're very high quality services, not just with that initial didactic and hands-on training we give the therapists, but what really ties us together are we run team rounds and office hours, which are kind of like an oncologic tumor board. You can't take a young therapist who really knows nothing about cancer, and they may have read this, but it hasn't stuck in. But when you start doing it in the context of actual patients, and you run through all the things like their eyes light up, and you start mapping what the impairments and what the treatments are to what they need to do. So that's become very successful. Our teams have gotten very good. Where I am at Kessler, we become a national and international draw, particularly for radiation late effects. We get, a couple of weeks coming from at least out of state, and they'll come and stay with us to do rehab. Our inpatient programs also haven't had quite the same attention. We're just really starting to build them, but those have gotten to be really superb, particularly at the Kessler hospitals and a number of others, our Ochsner hospitals in Louisiana, and Baylor and Emory and some of these others have really come on board. So that's what I do. I think it's kind of a joke. My life is like a 20-ring circus. I'm never quite sure what I do for a living, but most of the time I do still see patients 3 days a week. And then the rest of the time I'm trying to keep us on track with this program. But I have a huge national team who really does the heavy work, and I get to come in and go, why don't we try this?
That's amazing. And as you were saying, one of the challenges that we face as physicians, like when you find a very specific field that somehow you don't have so many colleagues practicing, it seems like you found a way to kind of scale or have a wider impact at scale that you couldn't do all by yourself. So that's amazing. And also
Yeah.
through the training program, that's, I think, one of the most powerful and impactful ways that how we can like impact other professionals and colleagues and people like recent graduates as well, as they are coming into these fields. So, but, obviously through the expansion of the services, and I was also got by your uh, concern about the financial component of treatment, which we know that it's a major factor to have in mind in oncology. So that's it's really amazing to hear you mention it as one of the drivers that led you to create these new services. But this leads me to my question. So obviously you've expanded the services, you've created this program that is training thousands of professionals across the US. What have you been seeing that's changing in oncology rehabilitation during the past decades?
Yeah, so when I first started, right, almost all of cancer rehabilitation was inpatient, right? It was at big academic centers, MD Anderson and Sloan Kettering and any place else. And again, part of this was the treatments were so morbid, right? There was a time we did radical mastectomies and we didn't have all these amazing drugs and we gave radiation at doses that would just not happen today. So those treatments became progressively less morbid as our oncologic knowledge improved. So while you still needed therapists in patients in the acute care hospital, that started migrating to some of the rehab hospitals associated. Like when I trained at Columbia, we were a unit like literally inside the physical hospital, even though we were kind of separate financially, we were physically inside. So those patients would come to us, but at a smaller number. If you're at MD Anderson, they're all right. Their inpatient unit with 100% cancer patients, right, coming to them. So that led to sort of knowledge in inpatient cancer rehabilitation, which, as you would imagine, was mostly brain and spinal cord, right? Patients who had brain tumor, spinal cord compression for various reasons, then a lot of debility patients. I remember it's not a good reason to laugh, but it just showed where we were. That my good friends at MD Anderson did a study on their transplant patients who were admitted to inpatient rehab and had something like a 35% mortality on their patients admitted to the rehab unit. So what that's saying is they were basically a shelving ground for the transplant patients who went south, right? And that was kind of the state of cancer rehabilitation 20 years ago, was just a lot of inpatient stuff. So now as the treatments got less morbid, oncology, as you know, becomes this big outpatient discipline. It's so much less morbid to treat a breast cancer patient now, right? And almost everything is done outpatient. Unless you have a complication or something that, is really complex or large, you're never going to see the inside of a hospital. You're just going to go in for your surgery. You'll be leaving the next day. For your radiation, it's in and out the same day. Your chemotherapy, it's in a nicely decorated, well-lit infusion suite that's all happy, happy. Now, it's been an evolution for the providers who are taking care of these patients on the oncologic side to understand what rehab can do. And that's been our biggest challenge, right? You can build it, but they don't necessarily come unless you really train them and teach them what we can do for them. And it's not enough to go say, oh, we're going to improve the function and quality of life of your patient. Like everybody thinks that's great. It's operationalizing that. And more importantly, believe it or not, if we're just talking among friends here, that same superpower I had at Sloan Kettering of making it easier for the oncologist. You want it to be an easy button. If they have to do a lot more to take care of these patients, they simply don't have the time and bandwidth to do it. So by decompressing them with our therapy teams, right, has really been pay dirt for the ones who are like early adopters. So the biggest evolution has been this inpatient outpatient evolution. And now really getting the oncologists, the administrators, the practices to understand what rehab can do for them. And the ones who really get it are huge, right? They refer literally everybody. It's just like a surgeon would never take anybody to the operating room without a baseline checks, x-ray, and labs, right? We have some who would never take a patient right, to cancer treatment without them first having seen one of our therapists to do an initial assessment, what we call prehabilitation, really prospective rehabilitation. So we can identify their issues, educate the patient on them, start training them what they could do to minimize those adverse effects, and then follow them as long as we need to follow them to get the best outcome.
Exactly. And that's a very interesting field, because if we look at this like rehabilitation field, and it includes physical therapy, exercise, nutrition, mental health, um, it should probably be the first treatments that we are offering patients right from the
Yeah,
diagnosis, right?
yeah. But
And
it falls through the cracks, time and money, right? And then also lack of resources, right? So even if you're 100% bought in to doing this, you may not have anybody who can provide the services for you. And that's what we've been trying. And one of the other things that's very different is because we have literally hundreds of therapy facilities, um, you're never in the places in the markets we have it. Like here in North New Jersey, where I am, I literally have 150 therapists operating out of like 100 centers, including PTs, OTs, and SLPs. And it's kind of a spoken hub model where when you come to Kessler West Orange, where my most complicated radiation patients come, those therapists get all the they're all super therapists, like they're all super knowledgeable and skilled. But it's like the guy doing 100 Whipples a year, right? You just get really good at it. And our therapists get really good at managing these super complex radiation patients and getting the best outcome. But then I can send them back to a local center. If you're just coming in with with fatigue, then I can send you to one of my faraway centers, and that therapist is going to be perfectly fine. And then we're still trying to train that therapist in the faraway center to take care of the more complicated issues, right, as they come through the door. And that's also part of the team rounds, right? So that therapist always, every week, several times a week, has an opportunity to get on a Zoom call with me and other senior people to talk about those patients and what needs to happen to them. And that really creates this, how do you yoke 1,000 people together to be one comprehensive cancer team? It's by having a lot of regular meetings where they can ask any question they want.
yeah, that's really interesting. And it's a true concern that we need to have in mind in oncology, that I think came more from palliative care. So in palliative care, we started having the first reports that people would rather be cared for at home and even die at home. And
Yes.
so we are kind of transitioning that still slowly in many countries, at least in Europe. But the sooner we can bridge the hospital with the patient's daily lives and communities, the better for both the healthcare systems that are not
Absolutely.
overburdened and for the patients. Right.
Absolutely. Yeah, we couldn't agree more. And that's one of the big focuses of our inpatient rehabilitation is identifying what we call our supportive pathway patients, meaning patients who are actively dying. And even if you're actively dying in the next month, 5 days with us means that we can give you a Hoya lift and teach you how to transfer. If you're a 75-year-old man dying of pancreatic cancer, there's a 70-some-odd-year-old woman potentially trying to transfer you who is at risk for all sorts of bad things. So training her how to help transfer you without hurting herself so that you can enjoy those last few days as well as possible, right? And so that's been a big focus of our inpatient, in addition to our, newly diagnosed spinal cord with prostate cancer, breast cancer that might live years, and doing sort of the full course of inpatient rehabilitation for them.
Yeah, that also touch on the advanced care planning part and the supporting the
Absolutely.
patient in a context of the family,
Yeah.
which is really a key part as well of our care. Thanks for sharing. But you were mentioning, for example, a patient with 70-something year old. So those are the typical patients that we used to have in oncology. But now we are seeing more and more young adults also being
Yeah, of
diagnosed, as we
course.
know. And these young adults usually have a much longer lifespan ahead of them. So they come with very different and particular challenges. So what do you see that are the specific challenges for this
Yeah.
population?
So the two big groups that come to mind are head, neck, and breast. So head and neck cancer, early stage head and neck, very curable disease for most, not all, but most patients, but almost always includes fairly high dose radiation, which is, devastating, a huge epidemic of HPV virus causing head and neck cancer. So I have people diagnosed in their 20s with head and neck who start getting all of these radiation late effects, what I call radiation fibrosis syndrome. I also call it the gift that keeps on giving because it's sort of this immortalized process that goes on forever. So they start getting, damage to the spinal cord and the nerve roots and the plexus and the peripheral nerves and the muscles in the field, dropped head syndrome, shoulder dysfunction, cervical dystonia, neck spasms, trismus, trouble opening the mouth, swallowing and speech problems, hearing problems, lymphedema, the face and neck, and effectively 100 of them. Carotid stenosis, thyroid disease, cognitive issues, the highest suicidality rate of any cancer group. So, to say they're a hot mess or likely to become a hot mess is not overstating it. So that group is, again, one of my specialty groups that I really enjoy seeing because while we can't cure them from the radiation late effects, we can absolutely make a huge difference and minimize a lot of the complications and talk them through it and, try to get them to accept a PEG before they're in the hospital for the third time with an aspiration pneumonia, right? And just let them live their best lives regardless of the treatment, right? And hopefully over time we'll get better and better at that. Breast, the same thing, right? So whether you've had a lumpectomy or a mastectomy, it's going to be lymphedema and breast surgery complications. What we used to call post-mastectomy now is probably better post-breast surgery pain syndrome, but the truth is the radiation is a big cause of it, and so is the reconstruction. Lymphedema is not just the arm now, a lot of chest wall lymphedema because of the breast conserving therapy, a lot of cognitive issues. The aromatase inhibitors are like fibromyalgia in a pill. So they're all achy and have all of these musculoskeletal complaints. And again, it's a lifelong issue. So if you're a 35-year-old diagnosed with breast cancer and you just had a lumpectomy and, just whole breast radiation, and now you're on an aromatase or tamoxifen in that case, you're premenopausal, you're going to be having issues forever that may get worse over time. So educating them without making them paranoid, but then empowering them to really manage those complications as well as we can with our current state of science, hoping that it gets better over time, is critical to us. And it's one of our favorite things. We talk about prehab, but the truth is, as I said before, I like the concept of prohab, prospective rehabilitation, where you're following them from diagnosis through treatment and then on into survivorship because they need it. Like the prehab part's really just love them and leave them, right? It really is too narrow a concept for me.
Exactly. And some of those challenges are very specific for certain treatments, but then for this young patient population, then you'll have, for example, a woman that may become pregnant in the future and may want to breastfeed. And they may not know if they can or how, or need also support in that part, like throughout the
Absolutely.
survivorship.
Yes.
And the same applies to fertility, and both for women and for men. So they come with very specific challenges that we are not always ready to address or to be open to. What I feel is that sometimes they are lost. So they finish treatments and it's like, okay, so you're cured from the cancer, so get back to your normal life. And it's
Right.
not the normal life that they knew, right? So it's really important that there are these sorts of services open to be available and willing to help them throughout the long survivorship that they may face.
Exactly.
And also, you discussed briefly the interaction of the different healthcare professionals that work on your services. And how do you collaborate with the other teams, such as oncologists, nurses, psychologists?
Yeah. Well, so as we at Kessler, at least, we're a freestanding rehab hospital, meaning we don't have an acute care hospital attached to us. So all of our patients arrive on an ambulance or an ambulette from another hospital in northern New Jersey. And for me, for the outpatient service, I get patients from literally all over the world, all over the country, particularly head and neck and Hodgkin's lymphoma survivors. But then that's probably a third of my patients. Then the other 3/4, or 2/3 rather, are coming from our local catchment in New Jersey. So there's a lot of oncologists who regularly refer to me. There's still a lot of oncologists that have no idea I exist or that our ReVital program exists, which is always just amazing to me. So for those, I have them all on speed dial, right? So I can easily call those oncologists. I get the notes and usually don't need much, and they'll email me or call me. I usually get a couple calls a day, and call people a couple times a day when you need to coordinate. You don't need to coordinate on every patient, and then try to get the notes back to them. We're all in a system where not all of us, but a lot of it are in Epic, where Care Everywhere allows us to see each other's notes for probably most of the physicians. So that's the communication with the physicians. For our therapists, I think that's even more critical. So I said like a head and neck cancer patient. So if you're a head and neck cancer patient coming to me, you're pretty much always going to go to PT for the postural issues, the neck spasms, the range of motion, that sort of thing. You're going to go to OT for lymphedema, right? We have PTs who do lymphedema, but just the way our payer system is, okay, I can send you to another. So, because they pretty much all have head and neck lymphedema, so we're going to educate them on that. And I'll usually try to get them a lymphedema pump as well, because I think that's important for long-term management. Then everybody gets a SLP, clinical eval, and a swallowing evaluation, right, with a modified barium study. So that's kind of my baseline. And if you're like great, then you may not have to go back to lymphedema ever. You may not have to go to SLP for a couple of years, but I continue to follow you, right, depending on how you're doing. And for us, again, it's these team rounds, which gives us the opportunity to talk about the patients. And, we see each other in the halls, for the complicated patients, we seek each other out. So it's a very good collaboration.
That's wonderful. And that's also my experience, that the physicians that have experience and tight connections and are aware of the impact that these interventions can have, they cannot not refer patients, right? Because they see the benefits. And
Exactly.
as you were saying, it also takes some part of what's not their main focus, which is treating the cancer. So it's a win-win situation. But regarding, let's say, the clinicians that are not on speed dial on your phone, what do you think are the most undervalued and underutilized, like potentially benefit services that you offer?
Again, the whole program, right? So, I mean, you're an oncologist. It is absolutely impossible for you to treat a patient without them having something. Like, there is no treatment that's benign unless you're like maybe shelling out a thyroid cancer, closing it up, and they're done, right? I mean, everything causes complications. So, in my estimation, pretty much every patient needs at least some degree of rehabilitation. So what's the high value stuff for them? The answer is it kind of depends. Like we as a group, right? So for ReVital, right? It's education, it's operations, right? If you've seen one cancer program, you've seen one cancer program, not all cancer programs. Everyone has a different way of trying to get your services to them. They have a different computer system. If they have Epic, they have a different instance of Epic. So getting into that is just, we have a whole team just dedicated to that, and it's hard. But then it's kind of winning the hearts and mind of the oncologist, which means you have to really kind of speak their language and learn about them. And it sounds bad, again, just among friends here and whoever else listens to this podcast, but it's kind of like a pharmaceutical or medical device company. At a certain level, to get your product to people, say you have absolutely the best new drug ever, but you're dealing with people who've only used that old drug. You've got to speak to the benefits of that, but not only in a way that the practitioner can receive and understand, right? And they're all very different, right? Some are very amiable and want to talk about your kids for hours. Some just want the facts and here's the paper, right? So we actually train our teams to try to do that because, again, we know all these patients need these services and benefit from it. So we want to work where they are, right? We want to be where the oncologist is to make those services available. And it's a lot. I mean, so we have thousands and thousands of oncologists referring into us now, and each one's different. And some will refer everybody, and some will only refer train wrecks, and which is fine. We will start with the train wrecks and we'll work our way down to kind of the appropriate level of care for your patient.
Thank you. And you also mentioned pain management. That's one of your areas of specialization.
Yeah.
And I'd like to go deeper there because, as you were mentioning, for most physicians, the pharmacological interventions are what we are taught. So we climb the ladder to the opioids. And so how do you approach it with rehabilitation, and at what stage, and what's the role of each for cancer patients?
Yeah, well, let's pick a patient. Let's take a breast cancer patient with still looking for a good term, post-mastectomy pain syndrome, post-breast reconstruction pain syndrome, whatever it happens to be, right? So we get this as another common one because it's a fairly common disorder. So if in the olden days, if you've gone to one of my fantastic, I mean, they're some of the best in the world, pain and palliative care colleagues at Sloan Kettering, right? They would have started you on an anti-inflammatory, maybe a nerve stabilizer, and then pretty soon a little morphine, and then a little OxyContin, then oxycodone, then a fentanyl patch, then methadone, right? I mean, they were working the ladder to try to find a treatment that worked for you, and maybe they would, maybe they wouldn't. And this is a challenging disease. For us, we look at it across a much bigger differential, right? So I'm torturing my residents all the time because it's so good to try to understand the pathophysiology of post-mastectomy or whatever we're going to call it, post-breast surgery. So there's two components to it, just to share with you and your audience, right? There's a neuropathic pain component, which comes from damaging the intercostal nerves of the branches off the intercostal nerves as they poke through the chest wall. These patients are going to have a little bit of anesthesia, hypoesthesia, allodynia, paresthesias, whatever, usually laterally, but sometimes medially because we've damaged those nerves. They're going to have intercostal brachial symptoms. That's the extension of T2. That's the pure neuropathic component. They get neuromas on these that can be, excited by activity. So every time we do something, you're mechanically hitting those neuromas and it's setting off your pain. Those nerves remodel, right? So when they remodel, they often remodel in the pain on position, which makes it now chronic pain. In addition to that, right, and it doesn't have to just be from those intercostals. There's also what we call pec minor syndrome, where the pec minor and the nerves running under them can be damaged, and that's very much a plexopathy sort of thing, and they'll often have pain out here, and that happens just from surgery, but then the radiation. Then they're going to have the muscle spasm, the somatic component, right, where that pec muscle spasming, the lat spasming, the intercostals are spasming. So for the doctor, it's figuring out what it is, and it's all history and physical exam. It's like you gotta, strip the patient down and you gotta start poking on stuff, right? Which is really uncomfortable for most patients, and our therapists even aren't used to doing that. But I'm getting in there and, digging in the pecs and digging in everything, and I'm testing the sensation over the breast and under the breast and all of that. And then once you've kind of done that, you can determine, is this more neuropathic? Is this more somatic pain, or both? So kind of no matter what you have, everybody goes to therapy. And why does everybody go to therapy? They're going to go to therapy so that you can take those neuromas that are frozen in this scarring tissue or damaged by the radiation and start normalizing that tissue with manual techniques, particularly myofascial release. Just that can help with the nerve pain substantially, because what do you do when you have breast pain? You're walking around like this all the time. Don't touch me, right? So everything gets tight. Those tissues just continue to get tighter, and it feeds into the problem. So we try to break that cycle, get the range of motion. A lot of these patients will have breast lymphedema that contributes. So we're treating the breast lymphedema. We may get them a pump that also treats the breast lymphedema. These new advanced pneumatic compression pumps. So that's kind of day one, is determining what it is, and everybody goes to therapy. And they may go to PT and lymphedema therapy, depending simultaneously. Then what do? Well, it depends on what you have, right? So if it's a largely neuropathic component, I may give you a nerve stabilizer, and I'm going to choose that based on what other collateral damage we want to do. If you have a lot of muscle spasm, the pregabinoids, right? So Lyrica and pregabalin have an anti-muscle spasm component as well as the neuropathic component. They also anxiolytic. So for the anxious patient, they're very nice. If they don't have a lot of that and it's really just nerve pain, then duloxetine might grade. It's nice. It's an antidepressant as well. So I'll choose a medicine based on that. Opioids have not been mentioned yet. They don't come into this for a long time. If the pec is spasming badly or the lats and it hasn't gotten better therapy, I'll Botox it. So I'm forever Botoxing the pec muscle and forever Botoxing lats and intercostal muscles, which is a little hairy, but it's really not that hard. And then I'll do other injections going after the neuromas with just, lidocaine and steroid, right? So the majority of our patients do fairly well with them, not all. Right, but most of these patients come out and, we're not going to make them normal again, but we're usually making them more functional. So that is very different from starting on Tylenol and working your way up to heroin.
It is, because you're not addressing the root cause or
Exactly. And we're very conscious of what we're doing, right? If we decide to have pec minor syndrome, we've got to stretch and mobilize the pec minor muscle. I can Botox the pec minor muscle. So forgive me, it's that accuracy of diagnosis and that basic understanding of the pathophysiology, which was not a thing when I started. Like, this has been an evolution for me figuring it out, and frankly, from the people I've trained telling me what I missed, right? Figuring it out. My third edition of the textbook. What's today? It's July 3rd. So it officially launches on July 7th. And it's been fun to kind of watch how these chapters have evolved in terms of our understanding. So post-breast surgery pain syndrome now has its own dedicated chapter because there is that much to know. Where I remember having the pain and palliative care people talk to us about it when 20 years ago when I was at Sloan Kettering, and all they could say about it is, yeah, oh yeah, the intercostal brachial nerve's damaged. That was literally the extent of their knowledge of the pathophysiology of post-breast surgery pain syndrome. And I'm sure I'm missing a lot. So anybody listening to this, I'm happy to hear your ideas.
Thank you. But in the end, I'll ask you to let us know where people can find you or more information about you.
Yeah, of course. Yeah.
For those who want to learn more. Another very common challenge that we have throughout survivorship is peripheral neuropathy. So can you tell us a bit more about your approach to?
Yeah. So that's actually another one. I hope you don't mind me just giving you clinical things because it is kind of illustrative of the approach. So the first lesson is just because your referral says peripheral neuropathy does not mean it's peripheral neuropathy. So that's like lesson number one. Lesson number two is you should always have radiculopathy in your differential. Okay. So the approach to peripheral neuropathy is actually to make sure, first of all, it's peripheral neuropathy. So let me give you an example. I had an 80-year-old guy, this was literally just this week, come from North Carolina because nobody could figure out what was wrong with him in North Carolina. So he came with his daughter for sort of pain on the balls of the feet. And he had a history of bladder cancer. It was a stage 1 bladder cancer. They just did a TURBT. They radiated the bladder. He got a little radiation proctitis. He had lymph node sampling, but he had nothing in the lymph nodes. And this was like in January or February. And of course, the pain predated that. And I think he got like mitomycin for chemotherapy, but that's not a significant neurotoxin. So he comes in, and I always send the resident into the room first. And our residents are fantastic. So this is never a disparagement on the residents. They're all amazing. And I always tell them the same thing. We're going to play the head to toe game. When you think about the differential diagnosis of any neuropathic disorder, I want you to start at the brain and work your way down to the neuromuscular junction of the muscle. So is it the brain? No. Is it the spinal cord? No. Is it the nerve root? She says no. Is it the plexus? Oh, maybe because they had cat, right? Okay. Is it the peripheral nerve? Maybe because that's what he came for. Right. So you're playing this game and thinking about the differential diagnosis, right, in this patient. So to make a long story short, without totally torching your audience listening to this, right, this predated, he didn't receive a neurotoxic chemotherapy. He didn't receive radiation or any other treatment to the pelvis that was likely to affect the lumbosacral plexus. And if it did, it would be the lumbosacral trunk, which is largely L5, which would be the top of the feet. This was his bottom of his feet, right? And when you examine him, he was strong as an ox up here, no sensory stuff, brisk reflexes in the uppers, briskish at the knees, actually able to get an L5 medial hamstring, and really nothing, I think, in the Achilles. And he was strong everywhere except a little bit of dorsiflexor weakness. He was like 4 on one side, 4+ on the other. EHL a little weak on both sides. Hamstrings weak, plantar flexors very weak. This was an S1 radiculopathy. So my neuropathy, and this is common. I can't tell you how many times I've had an oncologist, forgive me, send me a patient with bad neuropathy right here, right, which is in the median nerve distribution, meaning it's a carpal tunnel. So that's the first lesson of neuropathy, is make sure it's neuropathy. And you can have both, right? So when you see those old patients who get foot drops, they're getting foot drops because they have spinal stenosis. So this guy, my 80-year-old guy, the brisk reflex in the upper, he's going to have a tight neck, right? Meaning when I started with an MRI of the lumbosacral spine because that's where the problem, but I'll get to do an MRI of the cervical spine. And he's going to have cervical spinal stenosis. He's going to have lumbar spinal stenosis. So he has bilateral L5S1 radix. That's the cause of his symptoms. Had nothing to do with his cancer whatsoever, which is fine. Still happy to take care of it. So then the treatment very much depends. So now our therapists, knowing this, are going to go after the back. They're not going to be doing like nerve glides in the foot and just sensitization down there. They're going to go where the actual source of the problem is. And it'd be like the same thing for a carpal tunnel, right? You're going to go after treatments for the carpal tunnel and not neuropathy. So again, I keep emphasizing diagnosis, 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 and we emphasize it to our therapists in these rounds because the oncologists, forgive me, They don't know. Like, you're not trained in neuromuscular medicine. So when I find one who can talk about any component of neuromuscular medicine, that would be like me talking about neurosurgery. I know nothing, right? It's just a completely different level of training, right? So our therapists are going to routinely get patients who have just been sent really with the diagnosis of symptoms. And if they're going to be a super therapist and apply appropriate things, they need to kind of make the right diagnosis, which is why we emphasize it. So that's the approach to neuropathy. Then when it is neuropathy, right, which certainly happens, then it's the same thing, right? The therapists are in a position to actually improve their strength, improve their gait, improve their safety, stuff that I'm incapable of doing. They can do the skin desensitization, which I think is very important with the patients to try to get them to know what certain things should feel like. That is very important. They can retrain the autonomic nervous system because we often forget that that's a component, and some of the agents we use will cause autonomic neuropathy, and they can work on that with us. For me, other than therapy and making the right diagnosis, I got meds, right? There's no magic here. None of these supplements really work. There's been a lot of big trials on them, and none of them really do anything. The nerve stabilizers, so duloxetine's probably got the best evidence. I was actually the reviewer on I think it was a New England Journal or JAMA article that was its big prospective trial showing its efficacy in chemotherapy-induced peripheral neuropathy, and actually worked better for platinum neuropathy than taxane neuropathy, which I found fascinating and I did not expect. But pregabalin, gabapentin also clearly work. Tricyclics work, but have more side effects. Opioids work, but only in kind of extreme cases and if you need to. So that's the approach to neuropathic pain. There's no magic, right? It's still old stuff. And again, I cannot overemphasize the most important thing is getting the right diagnosis because it changes everything in terms of your approach.
It is. I think it's important, as you're saying, of course, the diagnosis, and I think that's the most important part of medicine in whatever we do, right? The same in oncology.
Exactly. Well, that's right. You can't treat anything without a tissue diagnosis, right? Because it's the same thing for us. And, and again, it's just what we're supposed to be good at. But a lot of times we're just treating symptoms. We're not really going after the root cause. Forgive me, it is an intentional pun of the thing.
Yeah, and I would also like to hear from you about the electrodiagnostic medicine. Also one of your areas of specialty, because this is not so commonly discussed in oncology.
Yeah, so that's kind of I'll admit that I'm not doing them really anymore, although I'm still maintaining my boards in them. But just because the knowledge, again, as I've moved into a more administrative role, it's just hard to have the time. But it is, it's one of those things that really helped me understand, like these head and neck cancer patients and these Hodgkin survivors. When I first started seeing them, nobody knew anything. There was no meaningful literature on their neuromuscular issues at all. And had spent a long time doing EMG, done a lot of it clinically, done hundreds and hundreds of EMGs. And when I was at Sloan Kettering, really had the time to do these EMGs. So I was able, and the patients, particularly the Hodgkin survivors, were really like, I just want to know what's wrong with me. So they'll stay in a room with me for 4 hours and let me shock them and stick them. If it didn't usually take that long, but if I needed, right? Because you're literally shocking them with electricity and measuring the impulses to select muscles. And then you're listening to the muscles and then activating the muscles with a small needle in it. But it gives you a tremendous amount of information interpreted properly. And it's actually one of the hardest things to do. So what I was able to figure out about these Hodgkin survivors, and I have a big monograph that I wrote years ago for the AANEM. It's a monograph and published in Muscle and Nerve. Was that they would have myopathy, like a Niemann rod myopathy in the distribution of the muscles, which is kind of it's like breakdown products from the muscles just being sick, right? And the myopathy you see on EMG because it's these really small, rapidly recruiting motor units. But in that same exact muscle, I'd have these big, giant neuropathic motor units. And I was able to kind of map them out. And I could tell they had myelopathy, like spinal cord dysfunction, just clinically, like they have brisk reflexes, they have clonus, they might have decursor sphincter dyssynergia. They had long track subacute myelopathy signs. You can't tell that on EMG, but I could absolutely see the radiculopathy. I could see plexopathy, right? I could see damage to the nerves in the radiation field, and then I could see these muscles. So I was able to, and I literally just made this up one day. to say that these patients have a myeloradiculoplexoneuromyopathy.
Mm.
And what that is just a way of saying this is the constellation of nerve and muscle structures that have been damaged, and then that is the cause of their dropped head syndrome. And the weakness of the rotator cuff muscles is why they're so protracted with the tight pec muscle. So the EMG was very helpful in determining that. Nowadays, I'd only even order because I'm really, like I said, I'm not doing them myself anymore, but I would only order one when it's going to change my management, meaning I don't know what's going on. So the fact that I did so many EMGs when I was at Sloan Kettering means I already know what's wrong with you before you get here. So I didn't really need to do it unless there's really a question that would make me think, like, say, oh, there's a superimposed disorder. Like, I think maybe you have a rheumatologic condition on top of your radiation late effects. Or if I think you just have carpal tunnel, is it severe enough to need decompression, then I would send you for the EMG.
Okay, thank you.
That's a lot if you don't do EMGs. I could go down such a deep rabbit hole, but it's not good for anybody.
Yeah, but I think that one of the best things about this sort of content and getting this available to people is that we understand that we are just scratching the surface in many areas, but then it's worth to know when to refer to specialists. And
Exactly.
I think it's a very valuable knowledge for all us clinicians, more than wanting to, I don't know, I don't expect myself to be able to write a nutrition plan. That's not our
Right.
goal, but I need to know when to refer
You
to
need to make,
nutritionists
exactly.
and how they
And
can
that's how
help.
I look.
Right.
Right.
And I think the same for rehabilitation, because that will allow us to refer patients timely and not miss opportunities.
Exactly. And one of the things I found in my career now is I've moved into, for lack of a better term, again, I'm looking for a lot of terms, a survivalist, meaning, doing kind of the cancer survivorship, because a lot of these Hodgkin's head and neck, nobody's really managing these. They might have a primary, but the primary is so out of their depth. Right. So I'm doing a lot of, making sure they're getting their echoes, their EKGs, right? Making sure they're seeing a cardiologist, pulmonologist, endocrinologist, and then kind of coordinating and managing all of that for the patient. So, and again, because a patient with bad heart failure is really hard to rehabilitate. So I try to get in front of those problems, right, from the medical side. And like you say with nutrition, I'm not managing their heart issues. I'm just making sure they're being managed and being managed reasonably appropriately. And I think that's a huge service that I'm hoping I can get all of my rehabilitation colleagues to sort of embrace, right?
Mm-hmm. And I think it's also one of the changes that we need to see, say, for example, in family medicine.
Yes.
Because our colleagues in primary care are not used to dealing with cancer patients or even survivors because they are seen as like oncology patients, so not for me.
Yeah.
But now with this increase in younger survivors and with a long life ahead of them, we need the training, we need them to be aware of all the things that can support this.
I agree. And I actually, though I kind of feel like it's like cardiology. I think it needs its own specialty though, right? In my personal thing, because I kind of look at it as the primary care, and I'm a board certified internist, and I can tell you from being an internist, I would be just from doing that training and passing my boards every time I have to again, I am woefully ill-equipped to take care of these patients because there is so much specialized knowledge, just like there is for cardiologists or pulmonologists. So I kind of advocate for these guys knowing more, absolutely. But some of these patients are just way too complicated, right? It's all these guys can do to make sure they're following the diabetes and the cardiac disease guidelines and making sure everybody's getting immunized properly. Right. I feel like taking care of a complicated head and neck cancer or breast cancer or gynecologic cancer patient is really kind of advanced class for somebody who does it all the time.
That's an interesting perspective. I've been seeing some colleagues in oncology dedicating themselves to survivorship.
Yeah.
It may as well just be something that we are seeing in the future,
Yeah.
like separate specialty.
I hope. I mean, and I think rehab physicians could do it, but they need more medicine training. Internists and primary care docs can do it, but then they need more of the oncology and rehab training, right? So I think at a certain level, it can be like pain management, right? You can go into pain management from rehab, from neurology, from anesthesiology, right? There's many groups that will coalesce into that specialty because they have kind of the core knowledge. But I feel like ultimately this really needs to be a specialty, just spinal cord medicine, right? So if a spinal cord patient has a primary care doctor, they're totally out of their depth for the most part in taking care of a quad, right? They still really need a spinal cord injury specialist, rehab doctor, or neurologist, but I prefer rehab doctor for obvious reasons, to kind of manage those things. So they are doing a lot of the medical management in these patients because other people just don't understand it, right? Or even if you've read about it, that doesn't mean you have the clinical experience in managing it. Just because you've seen one, just at least for me personally, makes me dangerous, right? I need to have seen a few before I've seen enough permeations to be good at it.
Yeah, it's true. And in medicine, we always need the two components, like the knowledge and the theoretical part, and then you need the clinical experience and the peer interaction.
Exactly.
Which is very valuable. And that's also really important, not only to refer patients, but also to reply to the patient's questions, because they bring more and more questions like, can I exercise? Should I exercise now, or should I kind of spare my energy? Or all those questions that they come up with. And what sometimes happens when clinicians are not enough prepared is that they give insufficient answers. And that, I think, it's one of the contributors to patients looking for alternative things before covering the basics, right? You see patients looking for alternative things, but not yet covering like exercise, nutrition, sleep, rehabilitation. So we can help
Exactly.
along there as well. Is there anything, Michael, that we didn't touch or didn't discuss that you think would be
Yeah.
important?
Well, I'd love to just say a little bit about the foundation because we did launch it, if that's okay. So, I'm going to say we just started, meaning me and Dr. Noble Jones, who is my past postdoc, who's now the director of inpatient cancer rehab at Emory, but really Dr. Diana Presno, who's a physician from Mexico who specialized in lymphedema and actually did the head-on management, became a postdoc through our Kessler Foundation and now is a research scientist working for us. It was really her idea and her pushing to start this International Cancer Rehab Foundation, which we started this year. We worked with the American Physical Therapy Association and with Kessler, or I should say Select Medical and ReVital, to make June, it's now July, the first International Cancer Rehabilitation Month, which I'm hoping everybody on this call will hear more about going forward. And the whole point of this foundation is to exactly do this, to kind of raise awareness for cancer rehabilitation and what it can do, how to operationalize it, what specifically to do. So to create training programs, ultimately certification, probably initially for physicians and then others, resources for patients. I have this sort of dream of having a registry of all the cancer rehab providers in the world, right? So patients would know who is where, right? And have that be sort of self-sustaining and monitored so people aren't doing silly things on it or saying they should be on it when they shouldn't. But really just breaking down the barriers to patients getting access to the services they need. I'd like to put myself out of business as the only specialist really taking care of radiation late effects because, I'm not going to be doing this forever and I don't want to be doing this 30 years from now because nobody else has picked up the mantle. So, this is kind of the goal of the foundation. We do have a website. You're welcome to just Google International Cancer Rehabilitation Foundation. And, people interested in just knowing more can reach out. There's an email there. And, ultimately, we'll hopefully have enough funding to get staff and keep doing it better. Our website's still kind of a work in progress.
Okay. Is it open for memberships, for example?
It's not even a membership, just we'll put you on the list.
Okay.
And it's open for supporters. So people who are wanting to support like the month, just send us your link and your logo. And the goal there is it's kind of the nidus, the beginning of this registry of people who are providing services. So right now we just want to get volume, then we'll start figuring out how to organize it, so patients can find what they need.
Amazing. And congratulations on putting that together. It's always
it's kind of like, being congratulated for getting a really hard new job. But thank you, I think. But yeah, we're excited about it. But, it's one of those things that, it's going to take a lot. So we're going to need a lot of help and support, like from the people who are listening to this call.
Yeah, hopefully this will help. And I'm definitely happy to help spread the message. And for us to close, Michael, is there, if you had a message to share with the healthcare professionals that are hearing us about the future of survivorship, what would it be?
Yeah, well, cancer rehabilitation restores function and quality of life, and pretty much every cancer patient out there needs it to varying degrees. So, start looking to build your own programs, right? And it doesn't matter that you know anything. Literally, I just showed up one day and was the cancer rehab guy at Sloan Kettering. So if I can learn it, anybody can learn it. Just literally still making it up as I go along, but so far so good.
Thank you. Amazing. It was a true pleasure to have this discussion with you and hear more about what you're doing. So thank you so much for joining me.
Thank you for having me.
And have a nice day.